I'm Jasper Kampman from Amsterdam, the Netherlands. I've been an anesthesiology resident there since 2020 and a PhD candidate since 2019. Amsterdam University Medical Center is the largest hospital in the Netherlands. We are at 2 locations now. I think one of the 2 has 25 ORs, the other one has 22. So together 47 ORs. And it's interesting to hear all the differences also in how we work clinically in all of our hospitals. I think we're not as big on recruitment maneuvers as we maybe should be. And we're also a big TIVA hospital, and sustainability plays a role in getting us there. And that's what I'm going to talk about sustainability in anesthesia, and also touch on change management and how we got to where we are now, and also a bit on the value of data sharing, and then especially on the paucity of available data right now about how we're using anesthetics worldwide, about what type of anesthesia we're using, what type of volatile agent, how we are using it. There's not much publicly available data. Oh yeah, do I just need to? Oh, perfect. Like I said, not much available data, but yeah, we've been talking about this the whole day, and this might be a solution, especially within a hospital. And I'm very happy that it also shows the emissions calculated into CO2 equivalents, and it shows how we're using our volatiles, which can be, of course, a lot more efficient than this, as we heard from Dr. Fisher. And also what agents we are using, because that's a very important choice. Quickly on my conflict of interest, these are the 3 research supports that I got, grants from the National Society for Anesthesiology, from the European Society, and also from the University of Amsterdam. And what it always shows that I also have a bit of a conflict of interest, because this is the Netherlands and the dark blue is below sea level. So I live and work a few meters below sea level. So yeah, that's also kind of a conflict of interest on the topic. Put it in as a bit of a joke, but it's also true. Short bit on climate crisis. Here are some of the consequences. You heard, of course, about the floods in the south of Spain, which may have something to do with it, but also droughts, fires, global warming, extreme weather. And this climate crisis is, of course, also a health crisis, because we're seeing more famines, forced migration, there's more exotic diseases spreading, also heart of lung diseases, cognitive disorders. And why should we care as physicians? It's because these people are our patients, but also because healthcare itself is a large polluter. Healthcare is responsible for about 4 to 5% of worldwide emissions, which, if healthcare was a country, would be number 5 in the world, the 5th largest emitter. And here is a 2019 study that shows a large number of countries and their footprint in a percentage of their national carbon footprint. And I'm sad to say that the Netherlands is at the top here, with over 8%. There's also a newer study from 2022 that shows that in the Netherlands about 7.3% of the carbon footprint originates from healthcare, but that we also use 13% of the raw materials in healthcare. So yeah, that's a good reason to try to reduce our footprint. In the OR, as many of you probably know, anesthetic gas can be a large proportion. This is a study that each of these circles is a different hospital, and they looked at the emissions originating from the operating room. And as you can see, it's a big, there are large differences between these hospitals. And they looked at anesthetic gases, at energy use, and the supply chain of all materials used in the OR. And this hospital is a Canadian hospital that was next to a hydropower plant, so their energy was really, really green. But then they used only desflurane, so that's why the anesthetic gases is such a large proportion. And then this is an American hospital that was less lucky with their energy, and also used a lot of desflurane, so it evened out a bit more. And this is a British hospital, which unfortunately was next to a coal power plant, but they did use only sevoflurane, so yeah, it shows what a big difference that can make. But yeah, in conclusion, anesthetic gases can be really important, and you can see the enormous reduction that we can achieve by thinking about how we use them. This is again a study from England. This is the entire NHS, the footprint of the NHS, and they looked at what different components of the NHS made up their footprint. And as you can see within the red circle, anesthetic gases and also inhalers make up 5% of the footprint of the entire NHS. So that's everything, not just hospitals, but the entire health services. And about 3% of that, so 3% of instead of 5% is from anesthetic gases alone. So if you can reduce that, that's a big step. Then something about why anesthetic gases are so make up such a large part. That's because of their global warming potential. For global warming potential, everything is in sustainability is calculated back to CO2. CO2 is like the currency of global warming. So CO2 has a global warming potential of 1. And for example, methane, which is a problem in agriculture, has a GWP of 86, which means that 1 liter or kilogram of methane equals 86 kilograms of CO2. So that's that's a lot. But then if you look at the anesthetic gases that we use, nitrous oxide has a global warming potential of 273, and then there's sevoflurane, which is 5 of 105, isoflurane, and desflurane is almost 7,000. It changes a bit over the years, but that's always been around 7,000. And then there's another thing that we use desflurane at higher percentages than that we use sevoflurane. So so just switching from desflurane to sevoflurane reduces your footprint by over 90%. Another way to reduce your footprint, of course, is to stop using these gases altogether. Which brings us to TIFA, propofol TIFA. May not be the solution for every patient, but it is. It does really reduce your carbon footprint if you stop using these gases. On the other hand, propofol TIFA has its own problems, which are more difficult to compare between the two than if just comparing sevoflurane and desflurane. I think this is a familiar picture. If you use TIFA, you end up with a lot more waste, and you have a lot of propofol that's left over, and you can't use that for the next patient. And that's also always the first question that I hear. What about all the syringes? What about all the plastic and all the propofol? And that really is a problem. There's a bit of a guess about how damaging propofol is to the environment, and that's based on something that's called PBT, which stands for persistence, bioaccumulation, and toxicity, and that's how every drug is classified. Here you see a couple of drugs that we use in anesthesia with their PBT. So they get a score for persistence, like how easy or difficult it breaks down in nature, which is between 0 and 3. All scores are between 0 and 3, so the total PBT is between 0 and 9. Bioaccumulation is how it accumulates in living tissues, like humans, but also other life on Earth. And toxicity is about how toxic it is. So propofol actually scores a PBT of 4, which isn't that bad. And then another thing is volume. We use a lot of propofol, but taken on large, propofol is not a medication that's found in large quantities in nature. There's a large, I think it was a Scottish study that looked at the top 20 medications that they found in surface water, and there were all oral medications that are used in much higher volumes, like antibiotics, oral anticonception, beta blockers, I think, and it's like non-steroidal anti-inflammatory drugs were also huge, but not propofol, luckily. But it does have its own impact, and it's a bit difficult to compare. If you just calculate it back to CO2 equivalents, like on the previous slide, it's a lot lower. Use TIFA, but it's not 0. Then something about how we did in Amsterdam UMC. This is our mission statement from our Department of Anesthesiology, and I think it changed in like 2018, 2019. They said, okay, sustainability is important to us, and it was not just our department, but it was the whole hospital. So also our hospital CEO really put sustainability as one of the top priorities in the hospital, and that really helps. So our mission is safe, and I like that they put it first because patient safety is of course our daily concern, main concern, comfortable and sustainable. And then how this is managed in the Amsterdam UMC is that we the statement is top down, but how we want to promote change is more bottom up. So we have a lot of green teams. Every department has its, I think now almost every department has its green team. The green team OR was the first green team in the hospital, starting in 2018. But now there are 65 on both locations, and we have a green community that get a newsletter every week and are involved in the sustainability project in the hospital. And over 2,000 employees are part of the green community out of a total of 19,000. I think Professor Ahmed also mentioned this, that you have to start with small experiments, pilots that you can scale up later. But it's important to have this long-term plan, like this mission statement, that sustainability is important in our hospital. We have a small multidisciplinary team. It's called the Center for Sustainable Healthcare. And it has two main functions. It looks inwards at greening our own hospital, like supporting these green teams, running this green community, but it also looks outwards with several PhD students, and it also works together with other universities and also outside of the Netherlands. And what is, I think, an important note that I put on it, that optimizing the current system is not always enough in the transition towards eventually a net zero carbon healthcare and a net zero society. That optimizing is important, but it's often has its limits. So it's also important to think about how we can change more fundamentally, like maybe the way we provide anesthesia. So I was going to say about how we did it in Amsterdam, and we're now in collaboration with our National Society for Anesthesiology doing a nationwide project. Step one was the research step. We wanted to have a solid evidence base about the effects on patient care when we're using less anesthetic gases. Our goal was never to really abandon them altogether, but to reduce their use. So we did two large systematic reviews, meta-analyses. One was on comparing TIVA with inhalational anesthesia, whatever volatile agent was used. And the other one was general anesthesia with or without nitrous oxide. There were a lot of RCTs available, as you can see. And we used, our primary outcomes were all related to morbidity and mortality. And we found no differences between the two. And then we had secondary outcomes that looked more at, it followed a bit the mission statement of safe, comfortable. First primary outcomes, are patients safe? Secondary outcomes, are patients comfortable? And when anesthetic gas were omitted, the meta-analysis showed that nausea and vomiting was less common, that emergent delirium was less common, especially in children, and that the overall quality of recovery, as measured by the Core 40 questionnaire, validated questionnaire, was higher when no anesthetic gases were used. So this strengthened our project to continue trying to reduce these emissions. So first we started locally in Amsterdam UC. Like I said, there was this top-down mission statement, and together with and it started with the Green Team OR a couple of years ago. And the first step was to discontinue desflurane. And out of this local pilot project followed the nationwide project together with the Dutch Society, and it actually has a I'm going to walk you through this. It had several steps. to get to a nationwide guideline to promote change. So the first step was the two meta-analyses, was the research phase. We also did a baseline measurement because, like I said, there's not a lot of publicly available data on the use of volatiles. So we did a questionnaire distributed to every anesthetic practice in the Netherlands to see what are you using right now, how are you using it. And we did it for the past couple of years to see if there was a trend. And a behavioral science firm helped us to do interviews with anesthetists to see what were their thoughts and concerns about the switch to from anesthetic gases to TIVA. And there were quite some concerns. I think a lot of people here also have concerns about the switch from anesthetic gas to TIVA. So it was really important for us to collect those thoughts. Also together with the same firm, we developed a communication framework on how to formulate the guideline. And it was also an open consultation phase for all anesthetists in the Netherlands to comment on what we had written, to make it a democratic process of coming to this guideline. What the guideline required was a local protocol on how anesthetic gases are used. Local practices were free to formulate their own indications for the uses of anesthetic gases. So it wasn't a mandatory you have to use TIVA, it was mandatory you have to think about the sustainability of your practice, and you have to together come up with how you're going to do this and what indications you see for TIVA and how you're going to use volatile agents. So without the adoption, writing of a local protocol was mandatory, but not the what was in the protocol. And we're going to, of course, study the implementation. What are people going to do with this, and also the eventual environmental effects of the protocol. So I'm going to show you now the data of how of the past, I think, 7 years, how we did it in Amsterdam UMC, and we're hoping to achieve the same results nationwide. So here are the years 2017 to 2023, and on the y-axis is not a volume of anesthetic, but it's calculated to so that's why we were never really big on desflurane, but only also a little desflurane already has a large carbon footprint. And over the years you can see that we abandoned desflurane altogether, and also isoflurane almost entirely. I think the last bit that's left here is from our animal lab. And in sevoflurane, this is about half what we used, what we initially used, and the total carbon footprint over these years decreased by about 80%. So we were, glad with these results. Then something on data availability, because at the start of the project we tried to figure out how anesthetics are used in the Netherlands, in Europe, worldwide, and there's not a lot about info and not a lot of publicly available data on this. Just a few months ago there was this study published in the British Journal of Anaesthesia, and it looked exactly at this. They could try to collect all available, publicly available data on anesthetic gas usage, and only these in Europe. And only for these countries there was some data available. So also the Netherlands is not on here because there's no publicly available data from the Netherlands, like for most countries. And for instance, for England there was one publication that detailed their 2018 anesthetic gas use, and that was it. So they have only this one dot. On the y-axis, by the way, it's CO2 equivalents per inhabitant. I think that's to make it a nice figure. And Scotland, as you may know, they already, I think 2 years ago, they banned desflurane altogether. So I think that explains their large drop. And for most other countries, it's stable. And most of these data was actually not from publications, but from national healthcare websites that had some available data about its use. Other data that's available is actually a pretty large questionnaire from the European Society of Anesthesiology, published 2023. And they distributed this questionnaire to the entire world. And this is I'll help you with the table because it's a bit, this is the total number of respondents, so over 1,000, and here's the total number for each part of the world, and then these numbers are percentages. And what they ask a few simple questions, so this is not about volumes, but this is just about, this question was, what anesthetic plan do you most often use? And in Europe, 27% said Tiva and 65% said anesthetic gases. And for every part of the world, it's a bit similar. And then these are the respondents again. So yeah, for Tiva it came to about 20%, and 2/3 is still uses volatiles. But yeah, this is a bit of indirect data. We don't know if the people who said Tiva also use a lot of anesthetic gases and the other way around. Another question that they asked in the same questionnaire was, what do you use? We can see that's 10% desflurane, also in Europe, but it's mostly sevoflurane, luckily. But still, this 10% desflurane, because it's so much more potent, has a much larger carbon footprint than these 83% of sevoflurane. Another evidence is more indirect evidence. This is a recent retrospective study from a large hospital in Korea, and it wasn't even about the choice of anesthetic, but they mentioned that 84% of patients received inhalational anesthesia and 16% total intervention anesthesia. Just to illustrate the type of data about anesthetic use that's out there, it's not a lot and it's not very detailed. But maybe it will. Just a quick teaser about an upcoming project that just got a successful grant proposal. I'm not one of the researchers, but my supervisor is. So just wanted to let you know that this is coming. They're still in the design phase. They want to include as many centers as possible and do like a measurement day to see what are people using, what type of anesthesia, what type of volatiles, what gas flows do they use, for as many hospitals in Europe as possible, to get a clear picture, because that's really missing, and it's very important. Just like Professor Moulinier said, it's essential to know what we're doing before we can try to improve it. So yeah, for every one of you who uses this, hopefully it's a very low bar to enter this upcoming study, because all the data is already available. So hopefully you will share it. And I want to leave you with this quote about, it was already formulated in 1987 about what is sustainable development. And sustainable development is meeting the needs of the present without compromising the ability of future generations to establish their own needs. And I think that's what we have to keep in mind. It's really important that we meet the needs of our present patients, but there's also our future patients that we also have to keep in mind. And this is a picture from the national campaign that shows this arrow with the way forward to try to enthusiase people to work more sustainable. So thank you.